So in the next presentation, I'd like to share with you some thoughts about links between patients' experience and that's right, and pathophysiology. In fact, pain in the joint is a really frequent condition, but as mentioned before, there are lots of misconceptions in this condition, lots of prejudice, and these misconceptions are in fact shared both by the patients and the physician. So in the next slides, I'd like to share with you some thoughts and to see how this patient experience fit with the pathophysiology, and if not, what can explain all these discrepancies. Here are my disclosures for the presentation. And as mentioned, joint pain in the joint is a very frequent condition with two main conditions. The most frequent is osteoarthritis, that in Europe may represent 20% of the population. And aside this degenerative disorder is rheumatoid arthritis or inflammatory rheumatism that in fact affect around 1% of the population. But in all these conditions, inflammation is a driver, peripheral inflammation. Pain is the first symptom, and associated with pain and inflammation, there is disability. And to start with, I should mention the first neuroscientist in the world was Hippocrates. And he described a very ancient theory that is the rheuma theory. What is the rheuma theory? The rheuma theory is the theory that describes that joints are driven by the brain. The brain sends more liquid to the lower part of the body, and the more there is liquid, the more there is pain coming from the brain. So this is very interesting to see that 20th century before the neuroscientist, Hippocrates already described these links between brain and the joints. Here are the 5 misconceptions that I found speaking with my patients and doing some quality research on joint pain with my patients. And we will go through these 5 misconception to see how the science may explain this misconception. The first misconception is the joint pain intensity is correlated to anatomical damages. The more I have pain, the more severe is my joint damage. We'll see that there is some correlation, but it is not true in all the times. In fact, joint pain is not a stable condition. There is rapidly destructive osteoarthritis. There is osteoarthritis with recurrent pain. And there is constant pain with progressive and slow evolution. And there have been one questionnaire that has been developed by ORC, that is an ICOAP questionnaire that defines 2 different types of pain in the joint: the constant pain that is probably more difficult to stand, and the intermittent one that is probably different, with different impacts in quality of life, on depression, on anxiety. So this is probably something that we should take into account, that joint pain is probably not the same for each patient regarding this instability. The global question is pain intensity. Is it related to severity joint damage? Here are the first studies, very ancient studies, demonstrating that there was no global correlation between pain and joint lesions. And in this study, 50% of patients had radiological lesions on the joints, but no pain, and also the opposites. More precisely, there have been some studies coming from cohort studies, 2 cohort studies. One is the most cohort. The other one is the Framingham cohort. And in these cohorts, the authors have looked at the correlation between joint damage that was defined with the Kellgren-Lorentz score that has two subtypes. One is the joint narrowing space, the other one is osteophytes. And they were able to demonstrate that pain intensity was not correlated to the presence of osteophytes. It was mainly correlated to joint space narrowing and only for severe lesions. That means that for extreme lesions, for very severe lesions, we have higher pain, but the majority of the patients don't have severe lesions. They have moderate lesions, and in this category of pain, there is no strict correlation between the severity of pain and the joint damage. So where the pain comes from, if you look at the MRI studies of the joints, and this is a study of several numerous knee joints by MRI that demonstrates that pain in the joints comes from different structures in the joint, but as mentioned this morning, from two major structures. One is the bone, and it's bone marrow lesions with an odds ratio of around 3. But the most important structure to consider in joint pain is synovitis with an odds ratio of 9. Meniscal tears are not very important in this globally in pain intensity, and osteophytes, cartilage morphology, bone cyst, meniscal subluxation were not associated with pain in this study. Another study, very interesting, looked at the patients with asymptomatic osteoarthritis. These were patients with lesions of the knees without any pain, and they look at the different types of patients according to physical activity. These were elderly patients without pain. That's not so frequent, but with some activity. And they demonstrated that lesions were some lesions were associated with the level of physical activity, and that were lesions of meniscus, cartilage, bone, edema, and joint effusion, even without any pain. So there's no strict correlation between pain and joint damages. And here is a very interesting study that looked at 4 categories of patients. The first one is low level of pain and low damage. The second one is high level of pain, low damage. The third one is low level of pain, high damage. And the last one is high pain, high damage. And you can see they tested the central sensitivity in these patients with mechanical thresholds, thermal thresholds, cold thresholds, and they were able to demonstrate that in the last group, the group of patients with high pain and low damage, high pain, low damage, that is the last group, sorry. And in these patients with discrepancy between pain and damages, that's the group where we can see the more central sensitization, the more decrease of pain threshold, mechanical pain threshold especially. So in fact, there are different kinds of patients and different correlation. And to conclude on this topic, joint pain intensity is correlated to anatomical joint damages only for extreme lesions. In the other categories, probably the pain sensitization, the central sensitization, may explain the discrepancy. The second point is joint pain is inflammation, and as a rheumatologist, I may say that it's the main pathophysiological mechanism that we know, but in fact, when you ask the patient to describe their pain, you will see that it's very different from one joint to another. From pain in a hand, where there are many times burning sensation, pain in a knee or pain in a hip, it's probably very different, and nociception and inflammation probably are not the same in these different joints. Here are a summary of periphery and all the structures that are involved in the periphery in the joint: the synovial membrane, the bone, the subchondral bone, the muscles, and as you can see, the cartilage is not innervated. And we may split the pain in different categories. First one is inflammatory pain that is probably related to synovial inflammation and where NSAIDs may be effective as steroid injection. The second one could be bone pain. Here you can see the bone marrow lesions and that are associated with joint space narrowing. As mentioned yesterday, there was a really interesting study that looked at the effect of bisphosphonates on joint pain. The first aim of this study was not pain, was to demonstrate the efficacy of bisphosphonate on structural damage in osteoarthritis, and it fails. But the secondary outcome measures of this study was to demonstrate the efficacy on pain. And very interestingly, this study demonstrated that zoledronic acid was effective mainly in these patients with bone marrow lesions and with a significant reduction of pain in these patients, especially in these patients. This is probably related to the efficacy of zoledronic acid on bone marrow lesions. But we should also consider that bisphosphonate has some analgesic effect independently on its bone effect, and there are very interesting studies on the direct analgesic effect of bisphosphonates. As I mentioned, there are lots of joint pain fluctuation. Pain is not stable from one day to another. And here is a very interesting course study looking at a longitudinal study looking at pain fluctuation from one day to another, demonstrating that bone marrow lesions are very important to consider in this pain fluctuation, with an odds ratio very important for these bone marrow lesions, and demonstrating that when pain decreases, it is associated with a decrease of bone marrow lesions in this cohort study, the most study. But joint pain is not only pain intensity. We should mention pain quality. And this is probably very interesting to consider. And here is a study we done, a qualitative study on patients with pain related to osteoarthritis. And for most of these patients, this kind of pain related to osteoarthritis is a very difficult pain because nobody wants to hear about it. And there is it's complex, changing, illogical, associated with aging. And to summarize, this kind of pain is also associated with the feeling of shame in many cases. So this is probably something also to consider when treating a patient with osteoarthritis pain. And in this study, we were able to demonstrate that pain experience in patients with joint pain has different dimension: sensory dimension, OA-related symptoms, variability profile, and the weather also can be important to consider for lots of patients. Pain triggering factor, mood and image, and general physical symptoms. This questionnaire is about to be validated to perhaps try to phenotype different types of patients with joint pain experience. Looking at that symptoms, lots of studies have looked at neuropathic symptoms in osteoarthritis, with lots of studies demonstrating that burning sensation, electric shock is present in these patients, with about 6 to 9% of patients reaching the level of neuropathic pain score. Here another study demonstrating that up to 28% of the patients with neo pain have neuropathic pain symptoms. And the last study demonstrating that with this kind of questionnaire, the PainDetect score, there were lots of neuropathic pain symptoms, and the more neuropathic was the pain, the more intense was the pain, and also less joint effusion in this patient. That looks relevant. So to summarize this second misconception, joint pain is not only inflammation, it's mainly probably in acute flares, but in chronic cases, bone and neuropathic components should be important to consider. The third misconception or topic that we have with our patient is all pain comes from the joints, and as pain specialists you probably know that it's not true, but we should speak about that with our patients, but also with surgeons, that thinks that when changing the joints may completely relieve the pain, and in fact, especially in knee joint, it's not the case. So as all pain, joint pain is an experience with tissue damage, but also all impact and changes in the life, in pain sensations, thoughts, emotions. And as a rheumatologist, this study for me was very impressive because I discovered that above the knee was a brain, and that the brain could be sensitized in patients with hip osteoarthritis. Here is the study that where punctate stimulation in the skin area around the hip was demonstrated increased brain activation in patients with hip osteoarthritis compared to normal controls. You look at on the right side, and this is something that I share, and when I teach to my rheumatologist colleagues, this is very important to consider to demonstrate that brain is something to consider in this patient, especially in osteoarthritis. Another very interesting study is this one, looking at the differentiation of brain activation between two types of pain: the constant pain, that you will have the brain activation, the spontaneous and constant pain on the right, that is really different from the evoked pain that is more somatosensory and that will, of course, respond more to classical analgesics, while spontaneous pain is not responding to classical analgesics and may explain perhaps the efficacy of duloxetine in this case. Central sensitization is something very important, and here is a study of pressure pain thresholds in patients before and after hip surgery. On the left, demonstrating that in patients with effective hip surgery, after surgery, the pressure pain threshold increased, demonstrating that central sensitization is not fixed and is related to the periphery. And again, the dialogue between periphery and the brain is probably more important with synovitis. Here is a very interesting study, again, demonstrating that if you look at the MRI finding on the joints in these patients and the central sensitization, synovitis is the most important structure involved when there is more central sensitization as effusion, compared, for example, to bone marrow lesions that are not so important in this study to induce central sensitization. So, not as you may expect, pain don't come only from the joint, and there are important links between joint and brain related to inflammation. The fourth point is that for many patients and also physicians, joint pain means aging, and in fact, aging take an important part in this patient, but not only aging. Obesity is also important to consider, local injury, and we should differentiate joint pain and osteoarthritis as a disease that is not the same. And it's not only aging. There are lots of studies, and I will only mention 2 or 3 studies demonstrating that there is a genetic influence not only on osteoarthritis, but on osteoarthritis pain. This is very interesting studies from Ana Valdez demonstrating that the mutation of one TRPV1 genotype leads to an increased frequency of osteoarthritis, but also of osteoarthritis symptomatic versus asymptomatic osteoarthritis. So there is an intrication between pain and osteoarthritis mechanism that is shown by this very interesting study. Another triggering factor for joint pain is also endocrine system and hormonal influences. And here is a condition that can be a model for joint in a pain. We've studied women with breast cancer treated by anti-aromatase treatment. That is a treatment that decreases completely the release of estrogens in cancer And in these 130 patients, we were able to demonstrate that 30% of the patients have pain, develop pain. The most frequent pain was pain in a joint, but in other cases there was diffuse pain like fibromyalgia. So there are hormonal influence on joint pain, driven here by estrogen. So this is also something to consider. And for rheumatologists, we know for a long time this postmenopausal rheumatism that occur during menopausal period. The last thing to consider for many patients is that joint pain is not treatable. There's such kind of fatality for many patients when being treated by physicians for joint pain. And in fact, we should consider that there are 2 different approaches. One for acute pain, where drugs, anti-inflammatory, surgery is probably very effective. And the chronic pain, as you know, that is multi-dimensional, where analgesics may be only one part of the treatment and should be combined with rehabilitation, psychological support, social support. And here are the way to treat chronic pain patients. This is adapted from rheumatological studies, especially rheumatoid arthritis, where we are not only looking at a specific change and how to change the pain, but also to go to symptomatic acceptable state. That is the PASS, the patient acceptable symptomatic state. And then we would like to go to normal values, but it's in this chronic pain condition very difficult. And we were able to demonstrate that the PASS, the patient acceptable symptomatic state in osteoarthritis, is 4 at rest, 4 on 10 at rest, and 5 on 10 in movement, both in hip and knee osteoarthritis. So that could be a point to consider with the patients to improve their quality of life. Pain treatments in joint pain are numerous. There are local, general, disease-specific treatments. And there's a lot of controversy considering paracetamol. Is there still a place in joint pain? If you consider all the treatments, paracetamol is poorly effective. But I should mention that probably we don't give the paracetamol for the right patient at the right time. It's not a treatment for chronic condition. It's a treatment for immediate pain, for immediate relief, and I think that perhaps it's not at the right place. Opioids are not very effective. Here are a meta-analysis demonstrating that weak opioids are better than strong opioids, and that perhaps may give us the feeling that the WHO letter is not relevant in this kind of patients. Antidepressants looks interesting, and here is the study on duloxetine demonstrating the efficacy on pain and function. But non-pharmacological approaches are probably much more interesting in this patient. Here is a study on CBT, cognitive behavioral therapy, that demonstrated an efficacy in osteoarthritis pain, but not in rheumatoid arthritis pain. Acupuncture is, lots of patients are looking for acupuncture. Here is the Cochrane review demonstrating that there is a small but not clinically relevant effect, but a small effect. And here is what's perhaps is the most effective treatment in knee OA, is the weight loss. And this weight loss is probably not only a local effect of weight loss, but also a systematic effect, because we know that when losing weight, there's probably changes in cytokines and especially interleukin-1 levels in the body. Few words on specific pain targets, future treatments. There are lots of treatments that can be considered. Anti-TNF is frequently used in rheumatoid arthritis and inflammatory rheumatism. Here is a study that was previously shown this morning, demonstrating that anti-TNF not only improve inflammation, but before improving inflammation, it improves pain, with this brain imaging demonstrating very rapid efficacy on pain pathway before activity on inflammation. This is perhaps the future for many of our patients, the anti-NGF treatment, where some effects, some side effects have been observed with efficacy that have never been observed as high before, but the story is not so good. There's also some side effects like rapid progressive osteoarthritis, mainly in patients with combination with NSAIDs. And finally, we should say to our patients that pain is treatable, even if for the moment osteoarthritis is not, and that the future is also good for if you look at all the treatments that may come. So to conclude, don't forget that pain is just an experience. Go back to patients' experience and phenomenology to validate all our pathophysiological models. Also develop animal models related to patient experience, and I think this is perhaps rat-reported outcome models. And I think that patient's experience may help us to define different phenotypes with specific treatment adapted to each phenotypes for better management of our patient. I thank you very much for your attention. Thank you.